So I've been asked to talk about atrial septal stenting, and this is an increasing procedure. As you know, the first intervention, pretty much in cardiology, but mainly in pediatric cardiology, was atrial septostomy, and this was for transposition of the great arteries. The difference between a septostomy and a stent is that with a stent you have a much more controlled and much more reliable communication between the two atria, and therefore there's an increasing need. Moreover, when septostomies were first carried out, hypoplastic left heart syndrome was pretty much 100% death sentence, whereas nowadays, obviously, this is a condition which is very commonly operated on in most places. So the main indications nowadays are for hypoplastic left heart syndrome, but also obviously for allied conditions like mitral atresia. Sometimes if you need repeated access to the left atrium, such as pulmonary vein stenosis that require repeated interventions, placing a stent helps, particularly for the left-sided veins. We do also place stents in the atrial septum for deflating the right atrium, such as in pulmonary hypertension. And there is a difference between a stent that you put in for a hypoplastic left heart as compared to the ones for, say, pulmonary hypertension. In other words, some have to be restricted, such as in pulmonary hypertension, whereas with hypoplastic left heart, you need to have it quite open. And sometimes we also need to fenestrate in patients with Fontan circulation. So that is very similar to an atrial septostomy, particularly in a classical Fontan, which is not done, or a lateral tunnel type of Fontan. The first thing that you need to do is obviously to cross the atrial septum. If there's a patent foramen available, you can use it. But sometimes the atrial septum, and not uncommonly, it's actually intact. And therefore, there are several ways of crossing this. The Brockenbrough needle is not the easiest, and it needs someone with quite a lot of experience to perform a transseptal puncture, particularly in small children. In older patients, it's not a problem. The radiofrequency wire or the radiofrequency needle are both possibilities, and these have the benefit of not sliding up and down the atrial septum, particularly if the atrial septum is bulging left to right. The problem, however, is sometimes the wire does tend to go beyond where you want to go. In other words, it can perforate the free wall of the atrium. The other thing is, as you all know, the aortic root is very close to the atrial septum, so you don't want to perforate the aorta with radiofrequency wire. There is another wire, which is the SafeSept wire, which is again designed to cross the atrial septum, but in a kind of safe way. However, increasingly, because of the availability and because of their properties, people are using chronic total occlusion wires. These are the wires that are used for coronary arteries and peripheral occlusions, and they are extremely good at creating perforations with a very small wire and with very little damage. Remember that when you're actually perforating with the radiofrequency wire, you're going to create a burn. And when you create a burn, the edges of the hole are dead. So you're not going to get spontaneous closure. If you perforate the heart with just a wire, then you still have live tissue around the hole, and that closes just like any other perforation does. So there are some benefits of using straight wires instead of using radiofrequency wires. You can use laser, but that is, in practice, not a very good one. So if we can just look at these, this is a neonate with mitral atresia, very, very, very sick kid, because there's no atrial communication. So he, within a few hours, we had to go and do an atrial septostomy, and then eventually a stent. And one of the things that you realize, particularly on the last image, is this one here, that the left atrium is very small, and that tortuous structure is, in fact, a very big left atrial appendage. We can actually use radiofrequency, and it's important to use ultrasound to actually place your wire. As I said, because it tends to burn at the site of contact, it doesn't slide up and down, unlike the transseptal needle. The safe sept wire is a very, very stiff wire with a nitinol tip, very sharp, and it's also curved at the tip. And the advantage is once it crosses into the left atrium from the right side, it actually forms a curve so that it doesn't perforate the free wall of the left atrium. However, these chronic total occlusion wires, and the company that makes most of them is Asahi, although there are others by Boston, Guidant, and so on, but these have the widest range and the widest experience around the world in occlusions, both for coronaries but also for peripheral work. And they are increasingly being used for perforation or for perforating pulmonary valves and opening up chronically occluded BT shunts. Sometimes the atrial septum is very, very elastic, and it is therefore important to have access to echocardiography. Obviously, in very small babies, you have to do a transthoracic like this one, but you can also use transesophageal in older patients to be able to identify your positions. In some patients, particularly where there is a lateral tunnel or even a TCPC, the material that is used is PTFE, as is shown in the top there. And these are very, very difficult to perforate, even with a transseptal needle. Sometimes the needle bends, and sometimes you have to have someone on the other side of the patient because you have to push so much that the patient actually almost moves, particularly in small children. So in this situation, you may have to use laser. The image at the top right is just a piece of plastic which we perforated with laser in vitro. The bigger holes are balloon dilatations, but even with balloon dilatation, the Gore-Tex tends to close down again, so these have to be stented. And this is one of our early stents, which we did almost 20 years ago now, in those days using a wall stent, as had been recommended by Professor Gavilic from Leuven. And the result was very good. This had to be done transhepatically. The patient was up for liver, kidney, and heart transplantation, and she eventually died. And this is why we have a post-mortem image on there, which shows that the stent was widely patent. In terms of the stents, there are different types of stents. In general, they're either balloon expandable or self-expanding, and you can either have them to full size, or you can have them in a sort of diabolo shape to control the flow, in other words, to have a restrictive access. In terms of getting into the heart, the commonest is the femoral vein, but sometimes we have to use the hepatic, either because the femoral veins have gone or in patients with azygos continuation of the IVC. Sometimes the internal jugular can be used, but this is not very easy because the orientation of the atrial septum is not right. And in some infants, transthoracic or hybrid approach is certainly a possibility. In terms of the sequence, once we're actually into the left atrium, we partially open up the balloon by placing the stent, the sheath halfway through the stent. Once we've opened up the distal half, we can come close to the atrial septum. You can do an angiogram through the sheath to know your position or position of the atrial septum, and then you can open up the rest of the stent, and then you get communication between the two. As you could see, that was a restricted stent. And the way we do restrict the stent is, as you can see down here, you place either a pacing wire, or I prefer to use Proline, and you decide on the diameter that you want. So, for instance, if you want a 4mm hole, you tie the knot over a 12-French sheath outside the body, and then you know that you have a 4mm hole. For the restrictive ones, it's better to start small and go big rather than to go big and come small. And once you've actually placed the knot there, you can then place the stent over it, and then that through the sheath. And once you've done that, what will happen is you see it over there. You can actually see a little bulge, which is where the knot is. You then open up the center bit, or the distal bit up to the center point there. You come down to the atrial septum. You can see the atrial septum here. The distal part of the stent is open. And then once you've done that, you can actually open up the proximal bit again. You've got a diabolo type stent here, in this case a 4 millimeter stent. We wanted it restrictive, and as this was done through the transhepatic, we closed it with a combination of a PDA plug and coil. In terms of unrestricted stents, you can use either balloon expandable or self-expanding stent. This is a CP stent in the atrial septum, and you can see a very, very, very free flow, maybe a little bit more towards the pulmonary veins. But remember, the left atrium is actually very, very small in this situation. And you can actually confirm that by having a transthoracic or, in older patients, transesophageal echocardiography. In patients with pulmonary hypertension, this can be quite a lot more difficult because the right atrium is huge, the atrial septum is bulging towards the left, and therefore the left atrium is very, very compressed. So this is a patient who does have very severe primary pulmonary hypertension, which was actually stented, initially with a 4 millimeter, but she developed more symptoms, and therefore we had to dilate that further. This is the stent here. You can see it in a diabolo shape, and we went from 4 to 6 millimeters. She also had atrial flutter, so we did a flutter ablation at the same time. And this is her echocardiogram. Again, you can see the stent in the atrial septum very nicely. We can see that it is actually conducting flow. But I think the most important is this one here. Can you see a huge right atrium, very compressed left atrium? So to get access to the left side without perforating the free wall can be a little bit difficult. So you do need to adjust the shape of your transseptal needle, and you need to be very careful. I'm grateful to Professor Gavilik from Leuven for these slides. This is a patient with a hypoplastic left heart who had a self-expanding stent placed, and you can see a very, very, very good flow from the left atrium to the right, and from the right to the left. And again, a detail of the same type of stent, which is a self-expanding stent made by Optimed, rather expensive, but they have a very low profile, and therefore very good for pediatric work. Most of the patients with Fontan these days do have TCPC, and it is difficult to actually perforate the conduit, particularly because it's curved, it's smooth, and it's difficult to orientate your needle to the right place. So it's easy to get out of the conduit in the wrong place. So our preference is to actually go from the top, as in this case here. You've got direct contact between the right pulmonary artery and the atrial mass, and it's very easy to go from there to there with a transseptal needle, and then you can place a diabolo type stent, and you can use this for fenestrations. We've used it for pacing. We've used it for EP work because the left atrium is not easily accessible, and if there are any arrhythmias in TCPC, that is how you need to get them. So there are some complications obviously associated with this. The transseptal puncture is not always easy, particularly in small babies, as I've mentioned, with pretty much any technique, although I think the chronic total occlusion wires are the safest. Perforation and tampon are the commonest problem. You can get stent embolization, particularly if it's not in a diabolo shape. And for small babies, you don't have to make it into a diabolo shape. Usually we'll go up to about 12 millimeters. You can get thrombus, so these patients need to be on aspirin. Over months, you can get in-stent stenosis, which is something which can be recognized, and it's not a serious problem, but it is a way of knowing that you need to intervene, and sometimes you can get late pulmonary vein stenosis. If you do need to limit the size of the fenestration or the atrial stent, you can either compress the stent, and you can do that using a gooseneck snare, or you can actually place one of these partial closure devices, which is made by Cardia. So in conclusion, stenting of the atrial septum has many indications, and these are increasing, particularly with the hypoplastic left heart syndrome program. There are different techniques and tools. I think it's important to learn several, but you don't need to know all of them. You need to use the ones that you're most comfortable with. The stent size can be varied. In other words, they can be, we're talking of the balloon expandable types of stents. You can make them very small or very large depending on the need. And remember that the procedure is not without risk, and therefore it is important to involve people within the team to make it as safe as possible. Thank you very much.